So this is the fourth and last lecture in the respiratory patho section. And now we're going to look at the difference between croup and epiglottitis. Croup this is a very confusing thing when you read in Kopstead, because they talk about croup and epiglottitis as two different things with very separate symptoms and so forth. And then when they describe croup, they say that it includes epiglottitis. That it's a group of diseases that includes epiglottitis. So that's very confusing to try and figure out what is what in there. But what it comes down to, croup is really just a general term for any childhood respiratory symptoms that include hoarseness, a barking cough, or what they call a brassy cough, that kind of sound, inspiratory stridor, and any kind of respiratory distress that comes from swelling or obstruction anywhere around the larynx. So in that sense, croup would include epiglottitis. But when we talk about croup, in most of the time, we talk about the most common occurrence of it, and that's acute laryngotracheobronchitis, or LTB. So when I talk about croup and when I test you on croup, what I'm testing you on is acute LTB. And that's actually what is the description of croup in your reading. You just have to read very carefully to understand that that's exactly what they're talking about. So the difference between the two can be seen if we look at a picture of the throat structures. This is a picture of an adult, but let's just pretend it was a child. Here, of course, are the vocal cords right here. Croup is swelling of the subglottic area down here. Edema. It's subglottic edema. That's what you're dealing with croup. Whereas with epiglottitis, you're dealing with the epiglottis right here, a swelling of that. And that's really fundamentally the difference between the two. Considering their functions, you'll see two very different set of symptoms. So I set up this as a chart so you can compare the two and contrast them. So the cause of croup, laryngotracheobronchitis, is usually viral. The flu, RSV, measles, and there is one bacteria that can cause it, the pneumonia, that particular pneumonia bacterium. The epiglottitis, the etiology is always bacterial. It's most commonly Haemophilus influenzae, streptococci, or staphylococci that will cause epiglottitis. The pathogenesis of croup is you have an infection, and it leads to an upper respiratory infection, and then that infection simply descends down below the glottis, and you get inflamed mucosa and a very narrow trachea and larynx. And you get the subglottic edema. That's the hallmark of what we consider croup, the most common kind, laryngotracheobronchitis. With epiglottitis, it's a little different. There's an infection, the epiglottis inflames, and then you have very rapidly an obstruction of the airway, because of course that's what the epiglottis does. It obstructs your airway so that at times, in a healthy person, so that you can swallow food down the esophagus. But now it gets swollen and starts obstructing the airway when we don't want it to. The child will get hypoxic, hypercapnia, that's increased CO2 in the blood, acidosis. There's decreased muscle tone and level of consciousness. And of course, if there's complete obstruction, the child will just suddenly die. Croup usually happens to someone less than 5 years old. In epiglottitis, we see it between 2 and 5 years old. Croup is slowly progressive. Epiglottitis is rapidly progressive, which happens very suddenly. Croup will show up as coryza to start with. That's an upper respiratory sort of nasal congestion is what coryza essentially is. With epiglottitis, the child goes to bed and then wakes up with a sore throat and very, very, very painful swallowing. The cough in croup is brassy or barking kind of sound like a seal, and the child is hoarse. The child is not hoarse in epiglottitis. There's no spontaneous cough. They'll cough if you ask them to, but there's no need to cough. They talk in a muffled, thick voice, and they have this sort of frog-like croak. But they're not hoarse, not like the child with croup. The child with croup has a low-grade fever with a sort of gradual onset to it. This child, the one with epiglottitis, has a high fever. There's inspiratory stridor on exertion with croup, And the inspiratory stridor with epiglottitis worsens when the child is put supine down onto their back, because the epiglottis tends to slide over the airway in that position. In croup, you'll see substernal retractions. In epiglottitis, you'll see retractions sub and suprasternal. The symptoms are worse at night with, let me get rid of these. The symptoms are worse at night with croup, and crying will worsen the symptoms. And in this child, the symptoms aren't necessarily worse at night. They drool because it's so painful to swallow with epiglottitis that the child will just simply drool rather than swallowing secretions. And the child will be, with epiglottitis, is what's called the sniffing dog position. Here's a picture of a child with epiglottitis, and she is doing just that. Her head's back a little bit, and you can't really see this, but she would be leaning forward, and her nose is tilted up a slight bit as if she was sniffing something, just like a dog does when they sniff something in the air. And this is a sign of epiglottitis. The child with epiglottitis will often breathe quiet and slow. And what's very distinctive between these two, and this is a very important thing to remember, the child with croup sounds worse than he or she looks. They sound horrible with that cough and the stridor, and it's very frightening to families. The child with epiglottitis, on the other hand, looks worse than they sound. They don't sound too bad. They're in much more critical shape than the child with croup, because they could die at any time. We need to establish an airway with them, and they're frightened, but they tend to be very quiet and leaning forward and breathing quietly and trying to keep that airway open. So they look terrible. They look quite frightened, but they don't sound too bad because you don't hear a big barky cough like you do with the other one. So that's an important distinction between these two diseases. The diagnosis for the child with croup is what's known as the steeple sign on an X-ray. And I'll show you a picture of that now. So this is the steeple sign. You can see it looks like a church steeple. Okay. And that's because of the swelling of the subglottis here is closing this area down. And that's why you get the steeple sign for the child with croup. Whereas with the child with epiglottitis, you're going to see what they call the thumbprint sign, which is shown in that dotted area there. It sort of looks like a thumbprint. And that's the swollen epiglottis, and it shows up on the X-ray. One classic rule in nursing has been around forever, and this may very well be on your boards, is don't do this to the child with epiglottitis. Do not do what this nurse is doing. You do not want to stick anything in their throat. This would be an older child, of course, but a child with epiglottitis would be younger than this, but still, never stick a tongue depressor, don't stick a culture swab, don't lean any object into the child's throat at all to try and visualize things or to try and get a culture. For the child with epiglottitis, you can actually cause the airway to close off yourself when you do this, and the child could die. And so don't ever do this unless there's emergency personnel and equipment at hand for the child where they suspect epiglottitis. Another diagnostic for epiglottitis, by the way, is because when they do see it, the epiglottis will be cherry red and the throat is red and inflamed, and the white blood cells are also elevated on a blood test. The main treatment goal for both of these is to maintain the airway. And the treatment itself, we want to make sure there's adequate respiratory exchange for the child with croup. Mild croup, that means there's no inspiratory stridor. Okay, then that's managed at home. And the child, and what we often tell the parents is take the child out into the cool night air, because cool mist seems to help. This is one of those not infrequent times when there's no evidence-based practice to support this, but practice in general seems to work. So people still tell families this. The child needs cool mist. So taking them out into the cool night air often will help tremendously. The cool mist is constricting the edematous blood vessels for the child with croup. Hold the child in front of an open freezer if it isn't particularly cool, or you're doing this during the day. Taking the child down to the basement if it's cooler down there will sometimes help too. And then, of course, when it's necessary, they'll give epinephrine and steroids. You don't want to let this child cry and cry and cry, because that will increase the swelling in the throat. So the ticket to that, is what makes common sense, is let the parents hold the child, rock the child, comfort the child. You don't want to be the sort of nurse that plucks the child out of the parent's arms and says, let me take care of this, because the parents have a very important role, which is to calm the child down, to decrease the crying, and that of course will decrease the swelling. And then of course you want to reassure the parents themselves, and the child needs hydration. Parents are obviously very freaked if their child is having difficulty breathing. Now over on the epiglottitis side, this is a medical emergency. Okay, so this child often needs to be intubated. Antibiotics or a trach may be another thing that happens. This is antibiotic stat, which may sound a little silly to you, that antibiotics have to be given immediately, but antibiotics can quite often have a very immediate effect. And you will see situations in other disease processes, which we may talk in another lecture, where every minute counts on getting the antibiotics in. So this would be one of them. We give, you want to reduce distress, so this child, because this child is quite scared because they're having a hard time breathing. And you want to reduce the stress, keep them calm as much as possible. And then, of course, we want to give the flu vaccine as a preventative to this, because Haemophilus influenza, one of the bacteria that frequently causes epiglottitis, tends to follow the flu. Obstructive sleep apnea we're seeing that more commonly now with a greater amount of obesity. Obesity is one of the main risk factors. So is smoking, being over 65, having a large neck, like mine, okay, a neck circumference that's greater than 17 inches, and then having some people just have structural abnormalities that they're born with. The pathogenesis here is pretty simple, so I didn't make a big chart out of it, but there's a small pharyngeal airway because of these issues, and then the pharyngeal muscles relax during sleep, which they do, and the airway simply obstructs. When we think of obesity, we think of people getting heavy on adipose tissue on the sort of on the outside of everything, just under the skin. But you need to remember, with obesity, the organs inside are being crowded as well, and the inside of the throat is simply building up fat tissue and narrowing down, and that's usually how this happens. So what happens here is the airway is obstructing, and now the person is hypoxemic and hypercapnic, and they're not breathing, and there's a startle response, and they'll breathe again. So they have a very terrible impaired sleep cycle. You'll see that very commonly with a person with sleep apnea. So signs and symptoms are very poor sleep. The person's insomniac, they're tired during the day, they have a morning headache. That's from the carbon dioxide building up in their system. Excuse me. Sorry. They have an inability to concentrate, and they're irritable, and you'll see personality changes from the lack of sleep. The complications are high blood pressure, cardiac dysrhythmias, because when people don't breathe, there's not oxygen getting to the heart. You'll see right-sided heart failure if it's bad enough, because the right side of the heart is pumping against an extra load trying to supply deoxygenated blood quickly enough to be oxygenated. Impotence, accidents, those come from the sleepiness. Quite often the person who catches onto this is the person the patient is sleeping with, because that person will say, my God, this snoring, I can't get to sleep myself. And that person may also witness the apnea. The diagnosis is a polysomnogram, which of course is a sleep study. They hook you up to many leads, and that is an overnight stay in the hospital usually. The treatment, a simple treatment, is to sleep on the side. The airway tends to stay more open that way. Increase the head of the bed. Avoid sedatives, because sedatives and alcohol tend to relax the airways too much. So avoid alcohol before bed as well. A special mouth guard. The CPAP mask, which I don't have a picture of, but the CPAP mask, you may have seen it. It fits tightly like an oxygen mask and delivers end expiratory pressure. It delivers what we call PEEP, positive end expiratory pressure. So at the end of each exhalation, there's a little burst of air. Some people are on the CPAP mask. Some people are on the BiPAP mask. Excuse me, BiPAP mask. BiPAP is spelled B-I-P-A-P, and those people get a little burst of extra pressure at the end of each inhalation as well as at the end of each exhalation. It fits very tightly, and it tends to keep the airways open. Patients hate them quite often because they sort of feel like they're being slapped in the face. So there's a lot of problems with compliance. And then, of course, surgery. Sometimes they will widen the airways, get rid of tonsils, that kind of thing, to make it the airway wider. Stop bang is a mnemonic. It is a test which we use to determine if someone is likely to have sleep apnea. This is used in the hospital. It's used quite frequently in the recovery room. Denise Miller, who works in the recovery room, uses this. Excuse me, I'm sorry. So, if someone has a history of snoring, if they're tired all the time, someone has observed that they have stopped breathing while they were sleeping, if their blood pressure is high, if their BMI is greater than 35, of course you may just ask their height and weight and do the math yourself. If they're over 50, if the neck circumference is greater than 40 centimeters, which is 15.7 inches, if it's a man, you can ask him what size shirt collar he has to wear, and if it's a male. Those are all those things are predisposed people to sleep apnea. Nobody has to have all these things to have sleep apnea. You can have sleep apnea and only have several of these things, but these are all risk factors. Actually, let me be more exact about that. If they answer yes to 3 or more of these questions, there's a high risk of obstructive sleep apnea. If it's less than 3 questions, there's a low risk of obstructive sleep apnea. This is an oral examination, which is also part of screening people for obstructive sleep apnea. And as you can see, as you go from class 1 to class 4, there's less and less of the structures inside the throat visible. With class 1, you can still see the tonsils, the uvula, and the soft palate. So it's all there. It's all quite visible there. With class 2, you can see the hard and the soft palate and just the upper portion of the tonsils. So we've lost part of that, and the upper portion of the uvula there. So it looks like it's sort of like a sunset. It's kind of going farther down. We can't see it. With class 3 down here, you can see the soft and the hard palate and just the base of the uvula right there. Right there. Okay. And then in class 4, all you can see is the hard palate. So obviously this person is the person most at risk for obstructive sleep apnea. And finally, we're going to compare bronchiectasis to bronchiolitis. Students often get these two things confused. Both of these result from inflammation, but they have two different effects. In bronchiectasis, the airways will dilate, so they will get wider, and they get pockets in them that fill with pus. And these are a permanent situation. People, once they get it, they cannot change the structural changes. They can learn to live with it and lead a fairly healthy life, usually. Bronchiolitis, on the other hand, is temporary, and this is also an inflammation, but in this situation, the airways are constricting. They're becoming narrower. Those are the two main, that's the two main differences. One is permanent, one is temporary, and one is a dilation, and one is a narrowing. When we look at the etiologies of these processes, cystic fibrosis, 50% of the time, is the etiology in bronchiectasis. Some people also just have a congenital disposition to it, an immunosuppressive or an inflammatory disease. For example, ulcerative colitis would be one example of an inflammatory disease that can lead to bronchiectasis. In bronchiolitis, the main cause is a respiratory syncytial virus. About 50% of bronchiolitis is caused by that. And then also the influenza viruses, other viruses, bacteria, allergic reactions. Respiratory syncytial virus occurs between winter and spring. Okay. And down here, the age for that is usually between 2 and 12 months. We don't usually see it after 2 years old. When you see adults who have bronchiolitis, that's usually they're smokers. And over here, with bronchiectasis, if it comes from cystic fibrosis, then it can be any time during that person's lifetime. And remember, those people, the median age is 31. They're living much longer now. For people who don't have cystic fibrosis, it's excuse me, less than or equal to 10 years old if it's a developing country, and between 60 and 80 years old. And that's because if bronchiectasis isn't caused by a cystic fibrosis, it's usually from some sort of disease that in a developing country can be treated with vaccines or antibiotics. So when we go up here to pathogenesis, there is, for bronchiectasis, there's a recurrent infection and inflammation of the bronchi, and the dilation is persistent, and that will lead to destruction of peripheral bronchi and the bronchioles from that inflammation or infection, and a loss of cilia. And then the cells change from columnar to squamous, and there is pus formation, which of course without the cilia you can't get rid of very easily, and that can actually lead to an airway obstruction. And the complications excuse me, are malnutrition, pneumonia, which makes sense, right ventricular failure because the heart is pumping against lack of oxygen supply from the lungs, and then the pus can move and you can get secondary visceral abscesses in other organs. With bronchiolitis, there's an infection, the bronchioles become inflamed, and you get the bronchial epithelium starts proliferating, it starts growing, which is why you see in this picture over here why they're starting to come together, getting closer together, and now there's a narrowing of the airway. And then remember, of course, that the epithelium is where secretions are made, and so there's this thick, tenacious mucus that is produced. There's bronchial constriction from chemical mediators. Surfactant gets displaced at the alveolus, and then because of the inflammation, there's fibrosis and airway narrowing on that level. Plus the products of necrosis are just causing obstruction. So all these things come together, and this person can get an obstruction. So when you look at the signs and symptoms for bronchiectasis, there is a cough. It's chronic, and there's copious amount of purulous drainage. You'll see someone will cough up blood, they can get fevers, and it should be night sweat, not night seat. The sounds of crackles and rhonchi, bad breath, and they'll get very pale, and they may do clubbing. Severity in bronchiolitis can be mild, or it can be quite, it can even be fatal though. There's quite a range there, and you'll hear wheezes, because of course those narrowed airways, crackles and decreased breath sounds. And then there'll be retractions as the person is trying to breathe as best they can, increased sputum, dyspnea, tachypnea, low-grade fever, and an ear infection can sometimes follow from this as well. And I do not know why. If anyone can figure that out, please let me know. The diagnosis, I have these written out for you, so I don't think you need me to read them out. You can just see them for yourself. They're all pretty self-explanatory. And the treatment for bronchiectasis are, of course, antibiotics. That's a huge issue there. Bronchodilators, chest percussion, postural drainage, good nutrition, and hydration. Any kind of respiratory infection or disease, particularly for a child, it's very hard to get good nutrition in because the child can't take time to swallow. They're breathing so much. They may do a bronchoscopy. A bronchoscopy is when the child is intubated, or when the child is intubated, they put the tube down, and they then basically have a tube which goes straight into the lungs. Of course, the child has to be sedated for this. And lavage means that they then wash it out. They just put solution there and rinse the lungs as clean as they can, and then suck all that stuff back up. For bronchiolitis, we give humidified oxygen, and then the bronchodilators, steroids to increase the swelling. Antivirals or antibiotics, because thinking of that preliminary cause. Sedation for anxiety, and then the person needs to be well hydrated. And that is the end of the respiratory lecture. Thank you very much. If you have any questions, you can email me or call me.